All right, welcome to Quickshot Session 1, Trauma and Critical Care. I'm Brad Thomas from Carolinas Medical Center. The format is going to be 5 minutes per presentation and 3 minutes for questions. There's no invited discussants with the Quickshot, so just line up at the microphone with the questions from the audience. And our first paper here to be discussed is going to be the 30-foot walls associated with increased severity and number of border crossing injuries from Dr. Doucet. Is that correct? Yeah, and from UC San Diego.
All right, thanks very much, Dr. Block. So, all right, that sounds better. With association with that increase in border wall height. So I work and live in San Diego, and there's about 66 miles of border between us and Mexico. We see about 15% of apprehensions in San Diego County and Imperial County of those along the entire border. And we split border call even in odd months with our sister trauma center, Scripps Mercy Level 1, which is just down the street from us. So it's the last 30 years, there's been a lot of changes in the border and the border wall policy. The first operation that kind of changed the border wall was then the Clinton administration, the Operation Gatekeeper. And you can see the original wall. It's still in place in many places. It's a 9-foot border wall made with perforated steel matting, World War II surplus from airfields in World War II. And we saw that with this wall going back in that day, we had papers showing that there was an increase in injuries with the creation of the fence. And this is some of the data from that period. So you can see that we saw that although apprehensions went down with the fence, the number of injuries went up. In 2006, under the Bush administration, there were 50 miles of wall built in 5 separate stretches along the US-Mexico border. This increased the height and reinforcement of the fence. Most of that was finished by 2011. And with that, we saw that as the fence went up, the number of apprehensions decreased. The number of trauma admissions, which had been going up, started to decrease again. Although there was a slight change in ISS, there generally was not an increase in severity of injuries with the Bush era fence. And this is the way the fence looked in 2016. Most of the places in San Diego and Imperial County, there was basically a 12 to 17-foot fence, usually separated from the original perf mat fence. In some places, though, it's just a vehicle bollard, so there's not really a complete fence. During the Trump administration, Executive Order 13767, the Board of Security and Immigration Enforcement Improvement the executive order was brought into action. This would build new barriers around 455 miles of the 1,933-foot border. Many places didn't have any border barrier before. Other places, though, including in San Diego and Imperial County, there was 30-foot wall built. And previous to this, there's been smaller walls in these areas. This was largely completed in 2019. Another event that occurred in March 2020 was the CDC invoked Title 42, which made it possible for Customs and Border Patrol to summarily expel people without a chance for presenting their case in front of an immigration judge, because these are considered expulsions rather than deportation. And this also had an effect on the number of people able to cross the border. So this is a retrospective trauma registry. We looked at border wall injured patients from 2016 to 2021. We looked at the 3 years in front of the wall as being before and after the wall construction in San Diego Imperial as being after. We looked at mortality, injury severity score, AISs, length of stay, and inflation adjusted costs, as well as mortality. We also got on-scene mortality from the San Diego County Medical Examiner for San Diego and Imperial County. The results, you can see this is since 2002, that after the creation of the 30-foot wall in 2019, there was a dramatic increase in the number of admissions due to border wall injuries. If we normalize that data by dividing it by the number of apprehensions by the Customs and Border Patrol, you can see that it's still relevant, that even though there is very little change in the number of apprehensions in this period, the number of admissions did go up quite significantly. Looking at the data, you can see the number of admissions increased from 67 to 375. Their ISS was significantly higher. The head and face IS went up considerably as well. There were many more head injuries with the 30-foot fence. The ICU length of stay was longer. The median hospital length of stay was longer. The median hospital costs after adjusting for inflation, this is cost, not charges, went up significantly. Hospital mortality, we didn't have any hospital mortality in the pre-phase, but we had 2 hospital deaths in the after. And number of apprehensions in San Diego period did not change very much during this period, but we did see 14 on-scene deaths, which was something we had never seen before for border wall fences. So a total of 16 deaths after the 30-foot wall went up. So we have some limitations. There's some different gaps in our knowledges. There are gaps in the fences. For instance, we don't know why some people decide to go over the fence and some decide to go around it. There are other kinds of deaths that occur as well, which we're not capturing here. People drowning, trying to swim around the fence or take boats around the fence by water, folks who are dying from heat and dehydration in the desert. And of course, this is all retrospective data, so we could be missing patients. But in conclusion, in San Diego Imperial counties in California, 2019-21, there was a significant increase in the number of border wall offense scenes. There are 14 border wall fatalities at the scene and 2 in hospital. The number of patients had significantly increased ISS. Their length of stay and costs were significantly higher. And we calculated the adjusted hospital costs from the surge in unexpected border wall admissions as being worth $13 million and $2120. And that's all I have. I'm pleased to take your questions.
While we're waiting on questions from the floor, I've got a question. Were there any confounders with COVID during the second time frame? I mean, there were only 2 deaths in the hospital, but were those from their injuries that was the cause?
No, there were no COVID-related deaths. No.
And how did you get accurate height information on the falls between your 2 groups?
Yeah, so the Border Patrol provided the data for the wall heights. However, the wall is quite irregular. We often tend to think it as being continuous, but in fact, there are many gaps throughout it. So you could have for instance, that gap I showed is actually in the eastern part of San Diego County. So you could have 5 miles of 30 wall fence and then all of a sudden a 200-foot gap with nothing and then more 30-foot wall. So it's very discontinuous.
So the presumed falls from the top of the wall, wherever the location is.
Yeah, and most of the falls in most of the areas, we think they're falling 30 feet. There are some places they could be falling us now. And of course, they take ladders and then try to lower themselves by ropes or use the ladder again. And so they're falling from various heights.
Question from the floor.
Yeah, we're just curious. So have you considered any like restitution to discuss with the state or the federal government with that $13 million surge in price to your?
Yes, we've spoken to the Department of Homeland Security through their medical operations medical officer about this. And obviously our institution is very interested in this as well, because of course, this is about half of the data. The other half of the patients went to Scripps Mercy. So you can double all these numbers in terms of cost. They saw a very similar number as well.
Thank you.
Yes, thanks very much.
Good morning, I'm Amy Kwok from UCSF Fresno, and our next presenter will be Dr. Christopher Foote from McAllen Medical Center, presenting evaluation of therapy in traumatic elderly falls to return autonomy and functional status.
All right. You said I'm Chris Foote, and I'm talking about elderly falls. I already had 2 talks yesterday about it, which I think was a great segue into mine. I have no disclosures. So the traumatic mechanical falls are a huge trauma population, specifically elderly patients over 65, and have reportedly cost $50 billion in healthcare costs in 2015. Readmission for subsequent falls from the index fall usually occur within 4 weeks. It's reportedly as 13 to 15% of the fallers. And falls are independently associated with a decline in functional activity after the fall, and recovery of that independent function is usually uncommon after 6 months with therapy or without. So with programs pre-fall and programs after discharge from the hospital to reduce recurrent falls already in place, I wanted to take a look at the inpatient care, what we're doing to reduce falls while they're on our service. So I wanted to look at inpatient physical and occupational therapy to hopefully decrease mechanical fall rates. we retrospectively looked at our level 2 trauma center admissions from January 2016 to 2021 with a 6-month window for follow-up to see if there were recurrence or any other injuries. We included 65 years and older and mechanical ground level falls, meaning they were ambulating under their own power at the time. Walker or cane was included. We excluded anybody who fell out of bed or wheelchairs, anybody that fell from multiple stairs, causes it to be syncope, stroke, cardiac. We wanted to just look at mechanical issues. So our primary outcomes, we were looking for recurrent fall rates. And for secondarily, we were looking at demographic data or any kind of predictors. We were looking for what kind of clinical course these patients would have for recurrent falls and what kind of therapeutic improvement they showed. We had 287 patients that fulfilled the criteria, predominantly male, which historically have been predominantly female for fallers, and our median age was 80. We looked at demographics, we looked at anticoagulation, we looked at injury types, whether or not they had surgeries, et cetera. We didn't really have much for significant predictors. And for our patients, 85% of them received therapy, and we noticed a recurrence of 18% compared to that 13-15%. We did have 96 all-cause readmissions, so we had decent follow-up for the 6-month for most of our patient cohort. And the things we found significant for those patients in our cohorts were that the people who did receive therapy are more likely to already have been using a walker or a cane for significance. Otherwise, the demographics aren't really telling us much. And for the readmissions, consistent with the previous literature, is documented previous falls were consistent with people who were gonna readmit for previous falls. For looking at the therapy itself, there wasn't really any difference between the duration of therapy with the patients who readmitted or didn't readmit, both with PT and occupational therapy. However, there was a huge variation in the population. Looking at the therapy itself, we used the 6-minute walk test since these patients were all ambulatory at the time of their fall. It was an objective measure that we could actually use for their clinical course. We saw that for people who improved their ambulation, they were associated with increased number of therapy sessions, 5 compared to 3. And when we looked at overall hospital course, increased therapy sessions was associated with longer hospital stays in hospital and ICU. There could be a correlation between, how injured they were. However, when we looked at the ISS scores, there wasn't really any difference between who got therapy and who didn't. However, length of hospital stay was significant for people who had obviously higher ISS scores recovering. The thing I found interesting was that when we looked at the actual deferral of therapy, meaning PT declined therapy that day for whatever reason, the patient decided they didn't want to do it, they're hemodynamically unstable, documented as like they were having dinner at the time, so they didn't get therapy that day, for whatever reason, that increased number of therapy deferrals was associated with longer hospital stays. And so our conclusion with that was that physical and occupational therapy didn't really prevent the 6-month fall recurrence rate. We had 18% compared to the 13 to 15 nationally reported. We did show that therapy does help the ambulation and helps their functional mobility, but it was also associated with longer hospital stay. But deferrals of therapy were also associated with hospital stay, and they could represent opportunity cost to the patient for improving their clinical course. It could be cost to hospital because of just the cost of care. And with the 6-month window for recurrent or recovery of function, we're really losing time on treating our patients while they're with us. So if we get to them early, get their therapy in every day, could potentially have reduced falls or just improve patient mobility at the time of discharge. So then they could go to those post-discharge therapy programs for inpatient rehab or home health or whatnot. So we could potentially improve their care by starting early and continuing to make sure they get the therapy. All right. And that's all I have for that. Question?
Great job. The floor is open for questions. So I have a question. So in our hospital, I think as with all hospitals, we are very, very busy, and physical therapy and OT are very, very busy. Do you have a specific kind of geriatric PT service or OT service that looks at your geriatric patients, or is it one PT that sees everybody?
It's usually whoever is available within the PT and occupational therapy specialty. They don't necessarily have a dedicated trauma or elderly related physical therapy to where they get seen. We do have certain physical therapists that will just see like ICU patients and they'll just continuously work with them because they're more comfortable working with them. But there doesn't really show any kind of regular specified care from any kind of providers. It's just whoever's available, like they just go when they can go. That could be something to look into, that they need someone more dedicated. The reason I came up with this project is because working in the cardiac ICU or working with other services, they do have within their whole global surgical package, they will work with PT, they will work with this stuff. A lot of the data is from, ortho hip surgeries where they're mandated, like you will work with therapy to like improve your discharge, to improve your functionality, everything after surgery. And even since submitting this paper, I noticed that there are several more papers looking at physical therapy with abdominal oncology surgeries versus transplant surgeries versus patients who just general surgical patients, to where they started instituting a mandatory physical therapy session. It was improving their discharge, it was improving their care at the time. However, some of those patients were planned surgeries and they were elective surgeries to where they already had a predetermined functional mobility beforehand. But with the trauma patient load, obviously for a lot of those ortho papers, they were excluding complicated trauma patients because it wasn't just the one hip fracture, it wasn't just the one knee injury that they were repairing. So, the trauma population being such a huge part of our service and huge part of our medical care, that have them not be looked at, I thought was something really good to look into.
Thank you.
All right, our next paper is going to be the outcomes of falls from height, border fence versus domestic related falls from Dr. Darwish, McAllen Medical Center.
Good morning, everyone. So I'll be presenting on the outcomes of falls from height, border fence versus domestic related falls. This research was conducted at the McAllen Medical Center. We have no disclosures related to this project. So domestic versus border fence falls. Fall from height is a very common injury mechanism seen at trauma centers in general. It's also one of the most common injury mechanisms that immigrants crossing across the fence incur, and as has been shown previously in the literature. So we thought to look at patients falling from a similar height on the border fence versus domestically and seeing if there's any difference in mortality between these two populations. We performed a retrospective chart review from April of 2014 to November of 2019 at McAllen Medical Center. Inclusion criteria was any patients who sustained a fall from a height of 15 to 30 feet, which was consistent with the height of the border fence and the McAllen area. We looked at patient demographics, length of stay, ICU length of stay, days on the ventilator, injury severity score, and mortality. 124 patients met inclusion criteria. 64 of those were fall from the border fence and 60 were domestic falls, giving us almost a 50-50 split. Our results here showed that for the domestic falls, they tended to be older. They were overwhelmingly male compared to compared to border fence falls. They had a equivalent overall length of stay, but patients that spent time in the ICU had a longer length of stay if it was a domestic fall. The days of ventilator were longer for domestic falls, and the injury severity score, which was probably explained by the GCS being lower on admission when they first came to our trauma center. While we did see 3 mortalities in the domestic population, this did not reach statistical significance. The limitations of our study are obviously this is a retrospective study. We had a relatively small sample size and it was limited to one institution. But this was a very local set of data relevant to our medical center. In conclusion, we saw that patients sustaining a domestic fall were overwhelmingly male. They were older, had a lower GCS on admission, a longer ICU length of stay, more days on the ventilator, and a higher injury severity score compared to patients sustaining falls from the border fence. There was no statistical difference in mortality between both groups though. Thank you.
Thank you. Waiting on questions from the floor here. The question I have is, do you have any other information about these two groups? These are distinctly different populations, and BMI information, medical comorbidities, to kind of elucidate the difference between the groups a little better.
Yeah, so at the time we submitted this abstract, we didn't have this data, but now that we have it, we noticed that domestic falls tended to have more comorbidities, more self-reported risk factors, hypertension, diabetes, dyslipidemia. So hopefully we'll show that data with our full manuscript.
Dr. Dusa.
Hi, J.D. from San Diego. I also noticed as on our data that you had a significant proportion of women falling to the border wall, which is a phenomenon. It's interesting. How much of your prolonged length of stay in the border wall was due to head injuries and open fractures, which generally I would find the injuries are generally more severe in these patients than domestic falls?
We honestly don't have this data yet. This was our next step in this data set. We're going to look at the pattern of injuries in these patients and what differences there is.
Thank you.
Thanks.
Next, we have Dr. Ashley Wilbers, and she will be presenting an analysis of missed injuries at a level 1 trauma center with the tertiary survey protocol, and she's from University of Kansas School of Medicine.
Thank you for the introduction. I have no financial disclosures. Multi-system trauma can result in both immediate and delayed morbidity and mortality. One potential source of delayed morbidity and mortality can be missed injuries, which are typically defined as those injuries not identified on primary or secondary survey. Reported rates of missed injuries in the literature can range anywhere from 2 to 65%. Factors that are known to be associated with missed injuries include head injury, decreased levels of consciousness, multi-system trauma, and higher injury severity score at the time of presentation. Anderson and colleagues originally proposed the tertiary survey as a way to potentially identify and treat missed injuries before they could result in morbidity or mortality for the patient. The purpose of our study was to evaluate a trauma protocol that required tertiary surveys be performed within 24 hours of hospital admission. This was a retrospective review of the trauma database at a single ACS verified level 1 trauma center in Wichita, Kansas. You'll note that our pre-intervention time period, our tertiary surveys, were performed upon the patient leaving the ICU or when patient participation was possible. We did have a washout time period of February 1st through July 31st of 2020 with a formal protocol implementation date of July 10th. Our post-intervention time period, we performed tertiary surveys within 24 hours of admission, regardless of whether or not the patient was able to participate in the exam. If they were unable to participate in the exam, then we required an additional survey when they were able to participate. Our tertiary surveys required all residents to review any imaging, labs, and perform a repeat head-to-toe physical examination. Our time periods are listed there, a 7-month period, exactly 1 year apart for both groups. 1,413 patients were included in our study, 762 of which were in our pre-intervention group and 651 in our post-intervention group. Demographics were noted to be similar between cohorts. Our patients were predominantly male, Caucasian, and with a blunt mechanism of injury. Our average injury severity score was approximately 9, and average GCS on arrival was approximately 15 in both groups. You'll note that our missed injury rate was approximately 1.5% in both groups, and our all-cause mortality was between 3 and 4%, which is similar to reported rates in the literature. Our protocol did succeed in increasing the rate of tertiary exam completion from the pre-intervention group, which was 80%, to our post-intervention group, which was just over 86%. We also succeeded in decreasing the amount of time to the patient having the tertiary exam. When you look at the actual injuries that were missed in both groups, you'll note that the majority were musculoskeletal injuries that were of little clinical consequence. However, I would note in the pre-intervention group, the most significant injury was a popliteal artery transection that was missed and did ultimately require amputation of the extremity for that patient. In the post-intervention group, there was a significant number of potentially clinically relevant injuries that were missed, including a grade 4 splenic laceration, a grade 2 kidney laceration, grade 5 blunt ileal injury, as well as an atlanto-occipital dislocation. Further analysis of our patients who had missed injuries showed that there was no significant difference in the number of injuries identified within 24 hours, nor the number of injuries that were identified on our tertiary exam. We use number of hospital days and injuries requiring operative intervention as a surrogate marker for morbidity, and you'll note that we did have a significant decrease in hospital days in our post-intervention group. Only one patient died of trauma-related injuries in our post-intervention group. However, it's important to note that he did not die of his missed injuries. He had other severe trauma-related injuries. In summary, the majority of missed injuries in both of our groups were musculoskeletal or orthopedic extremity injuries that were managed non-operatively. There was no difference in the missed injury rate or the mortality rate between our two groups. Our protocol succeeded in increasing the rate of tertiary exam completion, but did not make a change in time to identification of the injury or injuries that were identified on tertiary exam. Because of our patient population and study design, it was difficult to determine if clinically significant changes in morbidity occurred. This was limited by the fact that it was a single center retrospective study. It did begin as a QI project in January of 2020, so residents may actually have been implementing this protocol before the formal implementation date, which could potentially skew our results. No formal instruction was given on how to perform a proper tertiary exam, and no standardized documentation of the findings there was no standardized documentation of the tertiary findings. We also could not find evidence in the electronic medical record of patients who did or did not have that additional survey if they were not initially able to participate in the exam. In conclusion, requiring a tertiary survey within 24 hours of hospital admission can increase the rate of tertiary survey completion, but did not appear to affect overall clinical outcomes. This suggests that quality of the tertiary exam may be more important than the timing of the exam. I'd like to thank the Southwestern Surgical Congress for the opportunity to present today, as well as to Dr. James Hahn, our principal investigator on this study, and I will take any questions.
Jim Davis, Fresno, very nicely presented and an interesting study. So what explains the difference in your length of stay then? Because your injuries really don't look that bad. Is it just getting the orthopedic injuries fixed or PT delays or?
Yeah, so that was very difficult to determine. If you go back and actually look through all of the patients that were included in that post-intervention group, we had several patient outliers in our pre-intervention group that I think sort of skewed our data. Patients that were there for 150 days, for example, and that those are patient outliers that significantly affected our results, I think.
So one of the hardest things we do with the tertiary surveys is doing the tertiary surveys for our ICU patients. Mm-hmm. Do you require that for your ICU patients within 24 hours as well?
Yes. So in the pre-intervention period, there was some variability and there was no standardized way that we did that. It was very often an understanding between residents that before the patient was transferred from the ICU to the floor that they needed to have a tertiary, but it was never formally in place. In the post-intervention group, if the patient was admitted to the ICU and was there for 24 hours, they had to have their tertiary within 24 hours of being in the ICU before handing them off to the floor resident.
I have two questions as well. One is, since you didn't see a difference, are you still doing the early tertiary survey? And then the second question is the missed abdominal exam or the missed abdominal injuries in the post group look like things that should be detectable on CT scan. So you selectively CT scan, and was this abdominal pain that prompted a CT?
So to answer your first question, since this protocol has shown these results, we have standardized our tertiary survey documentation. And we have gone through and sort of educated residents about what you should be looking for and how the tertiary should be performed. We do still require, if the patient is awake and able to participate and make it a meaningful exam, that they have it within 24 hours. For those patients that may not be able to participate, either they're intoxicated or they have, severe head injury, they can wait several more days to see how they wake up. The problem that we were finding is that if the patient was altered when they first came in, they were not having their tertiary done in the ICU. And then when they were transferred to the floor, that transition, things were getting missed and forgotten. So they were being discharged from the hospital without a tertiary survey. To answer your second question, those specific injuries that were missed, that splenic laceration was missed in handoff from the day team to the night team. So it was seen on the CT scan, but the residents did not communicate one to the other. The kidney laceration was just a miss by the radiologist that was on call overnight and was quickly found and called to the day team as they were coming on. That ileal injury was a patient that had large ovarian cysts. And so she had free fluid in her pelvis, and there was some question about, was it due to a ruptured ovarian cyst or was it truly traumatic? She became peritoneal and was taken to the operating room within 24 hours.
Thank you very much.
All right, paper number 5 is falls among older adults during the COVID-19 pandemic compared to a pre-pandemic period, a case control study from Dr. Zayat, is that correct?
Yes, I'm only a medical student
Okay,
though.
okay, medical student Zayat from University of Kansas.
Thank you so much to the Southwest Surgical Congress for allowing me to present today, as well as our moderators, Dr. Thomas and Dr. Kwok. I'd also like to thank Dr. Hahn, who's with us today. Sorry, how do I advance? Oh, here. 28% of American older adults fall annually, which results in 36 million falls and 8.4 million fall-related injuries. 1 in 5 result in serious injuries, and falls account for 64 deaths per 100,000 older adults annually. This is significant since COVID-19 may present asymptomatically as falls in older adults. Therefore, the purpose of our study was to determine if there were differences in patient characteristics and hospital outcomes among older adults with fall-related injuries who presented during the COVID-19 pandemic compared to a pre-pandemic period. We conducted a retrospective review of trauma registry and patient medical records and included older adults aged 65 years and older who presented with traumatic falls during a pre-pandemic period, as denoted by the red text, or during the COVID-19 pandemic, denoted by the blue. Moving on to our results, the demographics were similar, with most patients being white females aged 81 years who were living in home or independently prior to having fallen. The blue highlighting indicates that more patients during the COVID-19 period arrived in shock when compared to their pre-pandemic counterparts. In contrast, the red highlighting indicates that fewer patients either fell in a rural area or were transferred from outside hospitals during the COVID-19 period compared to the pre-pandemic period. However, the time to presentation was similar. When we did do advanced statistical models and excluded transfer and rural admits, we did see that pre-pandemic controls were 31% less likely to have a delay to presentation compared to their COVID-19 counterparts, which was statistically significant. The Glasgow Coma Scale was also similar, as was the proportion of patients who were tested for alcohol use and the proportion of patients who had an elevated blood alcohol level. Alcohol use disorder, substance use disorder, cerebral vascular accidents, congestive heart failure, myocardial infarction, peripheral arterial disease, and atrial fibrillation were comorbidities that were seen more frequently during the pandemic. As for injury severity, the injury severity score and the abbreviated injury scale of the extremity were lower during the COVID-19 pandemic. However, other parameters of injury severity presented similarly. Most injury types presented similarly, with the exception of subdural hemorrhages, which was seen less frequently during the COVID-19 pandemic, and pneumothoraces and pneumohemothoraces that were seen more frequently during the pandemic. We also saw more complications during the COVID-19 pandemic, namely acute respiratory failure, hypoxia, delirium, and sepsis. Regardless of this difference in complication rates, the hospital outcomes remain similar, with a similar proportion of patients requiring ICU admission and mechanical ventilation, as well as a similar hospital length of stay. The mortality and readmission rates were also similar. However, we did discharge fewer patients to skilled nursing facilities and more to home with services during the pandemic. We did have 21 patients who are of confirmed COVID-19 status, and the most common COVID-19 specified therapies were oxygen therapy and antibiotics, and the most common COVID-19 specified complications were acute hypoxic respiratory failure and pneumonia. Moving on to our discussion. Our study revealed no difference in the time to presentation. However, when we did do advanced statistical models, we did see, and excluded for the transfer and rural admits, we did see a statistically significant delay during the COVID-19 pandemic, which was in concordance with the literature. We also saw more patients with alcohol use disorder, which may be associated with the higher incidence of delirium. However, interestingly, we did not have a difference in the proportion of patients who presented with an elevated blood alcohol level. Finally, fewer patients were discharged to skilled nursing facilities and more to home with services, probably due to the lack of available skilled nursing facility beds during the COVID-19 pandemic. This also highlights how we had to utilize other techniques to allow these patients to be discharged to home. Our study was inherently limited by its single institute retrospective design. Additionally, the pre-pandemic period was not directly a year prior. There was also the possibility of recall bias and confounding factors which might have impacted our results. In conclusion, we did notice differences between the two periods, notably that more patients presented with alcohol use disorder, more had complications, and fewer were discharged to skilled nursing facilities and more to home with services during the COVID-19 pandemic compared to a pre-pandemic period. Regardless of these differences, the frequency of falls and the mortality rate were similar between the two periods. Thank you so much, and now I'd like to open it up to any questions you may have.
Jay up from San Diego. Some of the differences in bed availability and discharge, how much do you think that was driven by facilities just not having beds? Because a lot of what happened during the pandemic is actually related to bed availability, not necessarily to patient factors.
Thank you so much for that question. That is exactly what we were thinking. We do not have data to support the divergence, I guess, of discharge. However, we were anticipating that fewer patients were discharged to skilled nursing facilities just due to the lack of available beds. Thank you.
I'm not sure that you would have this data, but do you have any long-term mortality data to see if there was a difference since more patients went home rather than to the skilled nursing facility?
Thank you so much for that question as well. We were interested in looking into that. However, we spoke to, I forget the department's name, and so I'm sorry, but they report 1 year mortality. And they told us that we had to wait until June of this year to receive that information.
Opportunity for follow-up. Nicely presented. Thank you.
Thank you.
Next, we have Dr. Williams presenting changes in characteristics and outcomes of ECMO for COVID-19 at U.S. academic centers from University of California, Irvine Medical Center.
Good morning, everyone, and I'd like to thank the Society for allowing me to present here today. I have no disclosures to present today. As we all know, since February of 2020, COVID-19 has caused many deaths and morbidity. So more than 80 million cases and nearly 1 million deaths in the US alone. Many patients that have COVID will go on to develop acute respiratory distress syndrome, and they are mechanically ventilated. For those patients who are mechanically ventilated and undergo all the adjunctive therapies that we have, such as prone positioning or paralysis for ARDS, but still continue to be hypoxic or difficult to ventilate, can undergo ECMO as a possible therapy. And of course, just to note that there are more variants that are emerging, and vaccination is one thing that we need to focus on. This is just a quick schema of when VV ECMO or veno-venous ECMO is indicated in ARDS patients, not specific to COVID-19. And this is from the ELSO organization, the greatest organization, the biggest organization for ECMO. Really, the point of this slide is exactly what I said. If you have severe ARDS patients that are not responsive to all the things that we can do to help them with ventilation, then ECMO is a consideration. There are contraindications, however. And really the absolute contraindications are anything that would make a patient not do well prognosis-wise at baseline. But one of the relative contraindications I want to highlight is age greater than 65, and I'll talk about that a little bit more. So we did do a previous study from my institution where we looked at COVID patients that developed ARDS, and they were managed with or without ECMO during 2020. This is a follow-up study here where we're looking at patients who had ARDS due to COVID, and they were managed, all of them were managed with ECMO, but we looked at 2 different time periods between 2020 and 2021. So we used ICD-10 diagnosis codes for COVID, ARDS, and respiratory failure, and we looked at procedural codes for ECMO, and we used the Vizient database, which has over 600 centers in it. And we used 2 different time periods, from March to December of 2020 and from January to August of 2021. Some of the outcomes we looked at, so patient characteristics, length of stay, mean direct costs, in-hospital mortality. In general broad strokes, so of the 3,500 COVID patients with ARDS that underwent ECMO, about half and half were treated in 2020 and 2021. There is a discrepancy there. However, we had a slightly different time period between 2020 and 2021. 2020, we had 9 months of data. In 2021, we had 8 months of data when we were looking at the results. So I think that that's why you see a slight difference there, not because we were treating patients with less ECMO. We had more female patients in 2021. We had fewer patients that were greater than 65 in 2021. And more Caucasian patients in 2021, which is likely more due to just the demographics of patients that were affected by severe COVID in the different time periods. Our lengths of stay and the direct cost were higher in 2021. One thought for that is perhaps we were doing better with treating patients with severe COVID, and we were allowing them to stay in the hospital longer, which of course drives up the cost, especially since ECMO is very resource intensive. One of the big things I want to highlight here is our in-hospital mortality. So ELSO did do a study previously looking at over 1,000 patients in their registry that were treated with ECMO, and their mortality for COVID patients were about 39%. Our numbers between the 2 time points were similar to one another, 51% and 49%, 1 in 2 patients, which is though higher than the ELSO registry findings. However, ELSO has high academic centers that do high numbers of ECMO, whereas the Vizient database is just any center that does ECMO. So there were several centers that only had 1 patient that they'd put on ECMO ever that was in the registry. So I think that's where you see the discrepancy. You can see here that another significant finding is that for the patients that were greater than 65, they had a slightly decreased mortality in 2021. I think that that's because we were putting people that were older on ECMO at a less percentage, like fewer people that were older. We were being more selective with our older population. Limitations. This has the limitations of every retrospective study that's based off a database. We are trying to look at data that's inputted, and that could lead to misclassification or missing data. The Vizient database itself only has in-hospital mortality, so it doesn't have long-term follow-up. And then we don't have any data on vaccination status or which variants patients had or what severity ARDS they had. So in conclusion, there were some changes in characteristics between 2020 and 2021. However, in-hospital mortality remained the same, even with longer lengths of stay. There obviously needs to be a lot more research done to try to hone in on which patients would do better on ECMO that have COVID ARDS. Thank you, and I'm open to any questions.
Nicely done. So did you have to change, or were there any changes in your criterias for people that you were putting on ECMO? part of that is greater than 65. Did you have to do any changes besides that?
So at our institution, because this was a database study, so I'm not sure across the board what everyone is doing, but at our institution, we became much more critical of patients that were over 65 that had obesity and really just being even more selective with any comorbidities. So we were trying to pick the younger patients that would likely do better just because one, during the surges, we were running out of ECMO machines and circuits and people that could run them for us. So we really had to start being pickier.
What do you speculate was the cause of the differences in demographics between the two time periods?
I have to look into it a little bit more moving forward, but I believe that it might just have to do with the fluctuation of the demographics in general of who was affected by COVID-19. I think at the very beginning, we saw minority groups affected very severely quickly. And then it kind of just broadened out to the majority being Caucasian patients. Thank you for those questions.
Thank you.
All right, paper number 7 is the coronavirus disease 2019's effect on geriatric trauma patients in Southern California. This is presented by Dr. Manassa from UC Irvine.
Good morning. I'd like to thank the Society for the honor of the podium today. We have no relevant disclosures. As previously mentioned, the COVID-19 pandemic has overwhelmed the healthcare system. In an attempt to mitigate the spread of the virus and decrease population movement, various state-issued directives were implemented, such as a statewide stay-at-home mandate issued by the California governor on March 19, 2020. Previous studies have shown that the trauma population has been affected by the stay-at-home mandate, including differences seen in the types of trauma mechanisms as well as outcomes. Previous studies demonstrated a decrease in length of stay and motor vehicle collisions, as well as an increase in penetrating trauma. Geriatric trauma patients, or GTPs, represent a particularly vulnerable and consistently expanding trauma demographic. Given their increased risk of mortality from COVID-19, as well as a concern for being hospitalized, along with the general trend in decreased population movement after these stay-at-home orders, we hypothesize a decreased rate of MVCs and shorter length of stay among geriatric trauma patients. We performed a multi-center retrospective analysis of geriatric trauma patients aged 65 years and older, presenting to 11 level 1 and 2 trauma centers across Southern California. Patients were divided into 3 groups across, depending on their date of injury. We were able to compare patients after stay-at-home orders, which was our post period, defined as March 19 to June 30, 2020, to patients immediately before, which we defined as our pre-period from January 1 to March 18, 2020. We also compared our post group to the year prior, which we use as a historical control from March 19 to June 30, 2019. Bivariate comparisons were performed. A total of 5,486 geriatric trauma patients were identified across the 3 time periods. Compared with the pre and control groups, the post group had a lower rate of pedestrian struck, 3.4 versus 5.8 and 5.2% respectively, and a lower rate of motor vehicle collisions, 7.6% versus 10.6 and 11.9% respectively. However, there was a similar rate of ground level falls and penetrating trauma across cohorts. Notably, you can see here we identified a low rate of penetrating trauma across all time periods, which we expected in this particular elderly cohort. Compared with the pre and control groups, the post group had a lower rate of discharge to SNF, which was actually mentioned, 20% versus 24%, but higher rate of hospice, 2.5% versus 1.5 and 1.4% respectively. Otherwise, we found that the groups were similar in regards to length of stay, ICU length of stay, operations performed, complications, and in-hospital mortality. There are several limitations inherent to this study due to its post hoc retrospective design and reliance on multiple trauma registries and data collectors. Considering this, it's possible that key data were either entered miscorrectly or misclassified. Also, this study may not be generalizable to non-trauma centers. And finally, this study only collected data very early during the pandemic and thus may not reflect the entirety of the COVID pandemic period of care. That being said, this study is strengthened by its multi-center design and in support of our hypotheses demonstrating lower rates of motor vehicle collisions and pedestrian struck for geriatric trauma patients, a finding that has been corroborated by prior studies on the general adult trauma population. As previously mentioned, this finding may be explained by decreased population movement as a result of stay-at-home orders. Contrary to previous studies on the general adult trauma population, this study did not demonstrate a shorter length of stay after stay-at-home orders were implemented. Perhaps the increased risk of morbidity and mortality in this vulnerable elderly population contributed to a similar length of stay, regardless of reduced hospital resources. It is also possible that decreased SNF and post-acute care availability during the pandemic precluded early discharge and may have resulted in similar hospital stays. Further studies evaluating post-acute resource allocation and long-term impact on the recovery of geriatric trauma patients affected during this pandemic appears warranted. Thank you again. I'll take any questions at this time.
Did you look at the actual COVID positive patients coming in, if there were a difference between that and the negative patients?
Sure, thank you for that question. We actually didn't look at COVID positivity as a characteristic. So it was really just comparing the time period for general patients with or without COVID after the stay-at-home orders were implemented. So we didn't look specifically at whether or not patients had COVID.
All right, thank you very much.
Sure. Thank you.
Next, we have geographic and financial considerations for ROBOA resources to address postpartum hemorrhage in Texas, presented by Aaliyah Conley from the University of Texas Health Science Center at Houston.
Thank you so much for having me. It's a delight to be here. The United States has the highest rate of maternal mortality in the developed world. It's estimated that 11% of these deaths are due to postpartum hemorrhage. And in the state of Texas, it's estimated that 67% of the deaths due to postpartum hemorrhage are preventable. Conventional methods of controlling postpartum hemorrhage almost always include transfusion to control for lost volume. Transfusion is costly and is often associated with many morbidities and mortalities, as well as an increased length of stay. ROBOA may reduce transfusion requirements and cost, and that refers to resuscitative endovascular balloon occlusion of the aorta. ROBOA makes great sense for postpartum hemorrhage, particularly proximal zone 3 occlusion. ROBOA has been used previously in wartime to control non-compressible hemorrhage of below the torso. Most usages have been reported in episodes of morbidly adherent placenta, and the gravid uterus receives blood directly from uterine arteries, as well as collaterals that branch directly off of the abdominal aorta. The goal of this project was to understand how much blood is being used in the state of Texas, both in terms of units and cost, and also to evaluate the potential financial benefit of implementing ROBOA for postpartum hemorrhage. We also wanted to identify counties and geographic regions that were most likely to benefit from this technology. We utilized a retrospective cross-sectional study with Texas Department of State Health Services inpatient public use data. We identified patients with at least one ICD code of postpartum hemorrhage and at least one unit of blood. We want to clarify here that blood units do not necessarily correspond to units of blood transfused. Rather, they correspond to all revenue codes associated with transfusion, storage, and cost of acquiring blood. We also use the Texas census data to look at urban areas in terms of metropolitan population, micropolitan, and frontier. So to look at how much, we wanted to identify both broadly patients with at least one unit, but also zooming in to patients with at least 25 blood units. And again, these units do not necessarily correspond to blood. They correspond to all of the costs associated with transfusion. We wanted to compare the total cost per patient of blood to the cost of a single Reboa catheter, both 7 and 4 French. We also, again, wanted to map cost and utilization by the patient's county and county designations. So what we found was looking broadly at patients who had at least one unit, you can see that our map here shows the darker regions corresponding to high per patient cost for blood, and our lighter regions correspond to regions that have a lower per patient cost of blood. We marked here all of the largest cities in Texas, and you can see that they're all located in relatively light areas, indicating a lower per patient cost. Of the 16,000 patients that were classified under postpartum hemorrhage between 2015 and 2019, we saw around a $4,000 per patient blood cost. And during that time, we found close to $70 million just for blood. When we zoom in to look at patients who had 25 or more units, the per patient cost between metropolitan, micropolitan, and frontier areas demonstrated a significantly higher cost for patients who are located in frontier and micropolitan areas. We believe that this might be due to the fact that patients in more rural areas have a limited access to ample blood supply and less of an access to larger trauma centers. When we compared the total cost of 4 and 7 French Reboa catheters to the total cost of blood for each of these regions, we found that $16 million in total blood cost for all 632 patients was significantly higher than the cost of a single 4 French or 7 French Reboa catheter. Now, this project is by no means to argue that all patients qualify for Reboa. And contrary, most patients do not qualify for Reboa, and this technology should be used in a very limited sense for patients who cannot be controlled with pharmacologic interventions or normal methods of compression. So certainly there are limitations to this work. It was a retrospective study. There are administrative and data inconsistencies. All of these hospitals self-report their data in the state of Texas, and we are also unable to see comorbidities and other potential reasons for blood loss in these patients. In conclusion, we saw that the total cost of transfusion is often significantly higher than the cost of a single Reboa catheter. Unit per patient blood costs were highest in frontier and micropolitan areas, and there was a potential $14 million in savings, assuming all of these patients did qualify for Reboa. Future work should look at the safety and efficacy for Reboa in postpartum hemorrhage, and looking more granularly at blood units as opposed to all units associated with transfusion. And this is work that Dr. Megan Brenner, Dr. Karen Fox, and Dr. Laura Moore are looking at with their PREGO trial. That is prophylactic resuscitative endovascular balloon occlusion of the aorta in gynecologic and obstetric populations. There also needs to be larger provider training to general surgeons, as well as obstetricians and interventional radiologists. Thank you so much, and I'm happy to take questions at this time.
JD San Diego, fascinating talk. Thanks for that. You're saying that the cost of transfusion will justify the cost of Reboa, but of course, the most expensive thing in healthcare is the providers and their salaries. And so Reboa is a significant escalation in care, and you do need to have a skilled general surgeon. And that's a difficult thing to do because, you know, even in we belong to the aorta group, most hospitals in the aorta group are doing less than 10 Reboas a year. So who's going to pay for all this expertise? And do you have any idea how much that's going to cost? Because you're going to need a lot of skilled providers to do this if you escalate these Reboa.
Thank you so much for that question. So we've actually found in the literature that most of our instances of Reboa, like you said, do require skilled providers. However, there have been numerous reports of Reboa being performed by interventional radiologists, general surgeons, and obstetricians. Certainly there needs to be widespread provider training on this technology, but we would also argue that in areas that might have limited access to blood supply, this could be the best intervention available. Providers should feel empowered to use all tools available to them. We've also seen that in lower resource areas more globally, a technology like Reboa might be more beneficial for women, again, because there's limited access to blood supply.
Justin Regner from Texas. Being a Texan, most of the frontier births are done by family practice providers. Do we have any experience with teaching the family practice group whether or not they can use Reboa and what that would entail?
That's a great question. So part of the issue with Reboa for postpartum hemorrhage is that we're not really able to look broadly at systematic randomized views of Reboa. Most of the work we have on it is individual case studies. So it's very challenging to look at how Reboa could be used from the perspective of family providers. From what we've seen, Reboa compared to other interventions such as internal iliac occlusion does provide numerous opportunities for family providers as well as general practitioners, surgeons, and interventional radiologists to use this technology, both to help patients potentially avoid the need of a hysterectomy, particularly in patients who might be younger and want to preserve the uterus. And yeah.
I think the other thing to look at is cost for OR time as well. So at our institution for our placenta accretas, we have the patients actually go to IR first, get their internal iliac artery balloons in, and then the trauma surgeons are actually in the OR placing the Reboa and waiting throughout the case in order to deploy or not deploy. So there's times for the OR, times for the multiple providers within the case as well, for the costs to look at. Thank you.
Thank you. Very nicely presented.
Thank you.
All right, our final paper for the session is changes in patterns of rural trauma center admissions during the COVID-19 pandemic. And it will be presented by Dr. Sarley from University of North Dakota.
Good morning. My name is Adrian Sarley. I'm presenting data from the University of North Dakota. We'll be looking at changes in trauma populations that we saw during the first few months of the COVID-19 pandemic. See if I can figure out how to work this. I have no disclosures. Since early 2020, COVID-19, as has been discussed many times, has changed life throughout the United States and the globe. It's difficult to overstate the impact this virus has had, from early efforts to shut down society to months and years of online school. Our society has experienced many profound changes. These changes have extended into our field of healthcare as well. Several trauma centers have reported changes in their trauma volumes during the early months of the pandemic. Philadelphia reported a 20% decrease in total trauma volume, although an increase in penetrating trauma cases. Pediatric child abuse has also been reported to have increased during this time. Johns Hopkins Children's Center reported a significant increase in the percentage of their pediatric trauma from child abuse during 2020 compared to prior years. To date, little is known about the effect of COVID-19 on trauma center admissions in more rural areas of the United States. These areas of the country experienced the pandemic in quite different ways than the more urban centers. We conducted a retrospective review at three trauma centers in North and South Dakota. This consisted of one level 1 center and 2 level 2 centers. The target time period was March through December of 2020, and we compared this with the previous 6 years, the same months from the previous 6 years. All trauma patients were included who presented during this studied time period, and data was collected from the institutional trauma database. Overall, trauma admissions in 2020 increased by 19% over 2019 admissions, and 28% over 2018 admissions. As you can see, there's a seasonal peak each summer corresponding to increase in outdoor activities. Interestingly, during 2020, we also saw an increased spike in October, which is when our region began to experience an increase in COVID cases. And you can see that again further here. The COVID cases are the line graph, and the bar graph represents the trauma admissions. And you can see in October, there's an increase corresponding to an increase in COVID cases. Not only did our absolute volume of trauma patients increase, but the composition of our patients changed as well. We saw an increase in all mechanisms of injury in 2020 compared to previous years. The largest relative increases were seen in the abuse and assault mechanisms of injury. As you can see, in 2020, we treated 59 patients with a mechanism of injury of abuse, which was an increase of 66% compared to 2019. And similarly, falls increased 247 patients versus 148, an increase of 67% from 2019. Interestingly, there was not a great deal of difference in the traffic accidents. I know that Dr. Manusa from UCI just shared with us their results in Southern California, but in North Dakota, there was not a great deal of difference. While many trauma centers reported decreased trauma volumes, our experience in the Dakotas was quite different. There are several potential reasons for this. The COVID pandemic produced significant shutdowns and lockdowns across the country. Social isolation has been suggested to lead to an increase in violence. In our sparsely populated region, the social effects may have been more strongly felt. Additionally, in our more rural area of the country, there were different reactions to COVID restrictions and lockdowns, which may have also played a role. This study demonstrates the importance of including rural areas of the country in trauma research. Rural areas are often understudied, and healthcare in these areas often differs significantly from more urban areas. Additionally, injury patterns are often significantly different, and better understanding these can lead to improving healthcare throughout the country. Any questions?
We also saw an increase in penetrating violent crime during the COVID pandemic. Do you have any thoughts on kind of further elucidating what might cause this difference in your population?
Yeah, I mean, I think our patients, the Dakotas are not a very violent region of the country, clearly. I think when people are forced to stay home, that leads to an increase in stress and a lot of differences in family dynamics that potentially could lead to some differences there. It's difficult to know exactly what's causing it with this type of study.
Yeah, I agree. It's hard to figure out what causes it, but it's certainly a national trend, it seems like. All right, thank you very much.
Thank you.
This one. Thank you, guys.